Good evening, everybody. Today I am being joined by CRGH Fertility Clinic in London, and Dr. Seshadri is going to be talking about endometriosis. What should you do if you think that you have it? What are the symptoms? How do people suspect or clinicians suspect that you may have it? And symptoms that may come with it, along with tests, procedures, and more. So she's here, I believe, now. I'm going to just join her now. Please have your questions ready. It's such a great opportunity. Nice to see you today. Hello, everyone. There we are. Hello, good evening.
Evening,
Welcome to Dr. Seshadri. How are you?
I'm fine. Thank you very much, Eloise. You've pronounced my surname perfectly. Thank you very much.
Lots of practice.
Absolutely. But thank you very much for hosting a very important point of discussion.
Absolutely.
For all of us.
So I've just given a brief introduction to what we're going to be discussing, which is a very, very important topic all around symptoms and awareness for endometriosis. And if people suspect they may have it, how will they know? So first of all, please could you introduce yourself and your role at CRGH Fertility Clinic in London, and then we can start talking about endometriosis.
Thank you, Elise. A little bit background, and I'm sure there are some people who've joined us live will already be very familiar with my background. So I'm a senior consultant and an accredited subspecialist in reproductive medicine and surgery. And I've had the pleasure and the honor to work with a fantastic team at CRGH. And we are at the forefront in terms of success rates in this country for infertility treatment and assisted reproductive technology. I also have had the pleasure not only being at the helm of this ship that delivers fantastic success rates, but it's all about, Eloise, being a team. And what I love being about working at CRGH is a fantastic nursing team, fantastic administrative team, and fantastic colleagues. Absolutely. So thank you for having us.
Summed it up beautifully, and for those who don't know, I have sort of experienced being a patient with you back many years ago when I had lots of testing done with CRGH, and I have nothing but a positive experience in your beautiful London clinic. So yes, I agree with everything you said. So talking about endometriosis, first of all, what steps should someone take if they suspect that they may have endometriosis and they're trying to conceive?
Very good question, Elise, but a little step back in terms of the background, because there could be individuals joining us who are a little bit unaware of endometriosis.
Yes.
Background. Endometriosis, very common condition, affects nearly 10 to 15% of reproductive aged women. There is a recent British Medical Journal publication in 2022 that ascertains that endometriosis could affect 190 million women and people assigned female at birth. This was published at 2022. We are a year on, and I think the incidence is going to increase. We also need to remember that not all symptoms could be indicative of endometriosis. So the purpose of this Instagram live is not to scaremonger everybody to reach out to their GP or gynecologist, but to give an idea. So to answer your question a little bit about steps to address their concerns, I've had the opportunity and a great honor to work by the side of an individual called Carla Cressy, and she leads the Endometriosis Foundation organization. And being an endometriosis, having the condition herself, she has got a symptom checklist. And I would urge everybody to follow her endometriosis organization just to see the checklist and to check if they have that symptoms in order to reach out to a healthcare provider. But say, for example, there is a suspicion and the couple are trying to conceive. The most important thing is to consult a healthcare provider. And where better to start than CRGH, Great Portland Street, because we've got a team of specialists. We also have a 15-minute free slot. nowhere in the country that you would get 15 minutes of undivided attention with senior consultants in this field. So avail that opportunity and have a brief discussion on how to proceed. But more importantly is also to have a medical evaluation and a consultation where the consultant can go through the history, organize a little bit of investigations, be the investigations of vaginal pelvic ultrasound, or maybe an MRI if required, and also to possibly discuss a little bit about the partner. So if they are trying with their partner, remember male health issues are leading globally as well. Again, not intending to scaremonger the audience, but also very importantly to reach out and at the consultation discuss different options. Why is the consultation important? Because we all live a very busy life and there could be certain lifestyle modifications, support and counseling sessions that we could offer at CRGH that could aid the couple in conceiving naturally even. Now, please remember, we need to remember for everybody who's joined us in that endometriosis does not necessarily mean infertility or subfertility, because many individuals with endometriosis can successfully conceive with the right medical guidance and support. And that's why I think you're particularly asking this question, Eloise. The best course of action would depend on the individual couple's specific circumstances. So working closely with your GP or your fertility specialist is very crucial in managing both endometriosis and the pursuit of pregnancy.
Just asked about CRGH, please do head to our link in bio to find out more. And as you said, you do offer mini consultations, which are free, which is an incredible opportunity to speak to top fertility specialists to get personalized advice and next steps. I want to ask you, before we go into more about symptoms and misdiagnosis and all of everything that we have to discuss today around endometriosis, what is endometriosis?
Very good question, Elise. Endometriosis is nothing but akin to the tissue which is present in the lining of our womb, that it's stopped through a process called retrograde menstruation, i.e. We normally menstruate out, but certain individuals have got the capacity to essentially menstruate through the tubes, and therefore the spots of the lining of the womb can line the pelvis. So every time we individuals have period, we essentially bleed in our pelvis, and those little endometriotic-like tissue is termed as endometriosis.
Am I right in thinking that this can grow outside of the uterus?
That's spot on. Essentially because of the thought that it could travel through the tubes and sit in our pelvis. It could be on our ovaries, it could be our pelvis, and even extraperitoneal organs, very rare case reports even in lungs.
And why is it often hard to diagnose, or why do people go undiagnosed for many years?
Very good question, Eloise. The reason being is there are varied symptoms. And as I said earlier, 20 to 25% of us individuals don't have symptoms and we just leave it. And then we have an incidental scan for some other reason, and then we pick up endometriosis. So there is no guidebook into the right symptoms, and I'll give in the course of our questions, I'll give you a little bit of an idea of the plethora of symptoms so that at least individuals are aware. And the idea is not to scaremonger everybody, but to be vigilant of our own health.
Absolutely, because if you can act on this and seek the best care, such as with yourself or with the team at CRGH, it puts you in the best position, doesn't it, to work out next steps depending on what you're looking to do, whether that's fertility preservation, whether that's having a child now, just advocating for yourself and having as much information as you can about your health or reproductive health. And I know from friends who have struggled with endometriosis, which has been misdiagnosed or taken a long time to diagnose, that often, they've had episodes where they've been doubled over with pain or may have fainted with pain, and it's been thought of as just a bad period. Have you seen that a lot with patients who've come to you?
Exactly, Eloise, because the question is a heightened awareness, not only among individuals. We need to, as doctors, also be heightened aware of this condition of endometriosis. And, one symptomatic painful period may not be suggestive of a diagnosis, but that could actually initiate investigations like a transvaginal pelvic ultrasound or even an MRI. But the question is, you're spot on. Quite a lot of individuals go undiagnosed because there's no streamlining of investigations. There is no exact flow chart or an exact textbook rhythm to follow in terms how to refer. But the big thing is vigilance, being aware of the condition, early referral to a secondary care center like the local gynecologist, and even a tertiary care center to further investigate if there is a possible diagnosis of endometriosis.
And is endometriosis hereditary?
Very good question. In fact, the Oxford team were looking at that, where they're looking at certain genetic markers. And at the moment, there is no exact particularly gene mutation that could put certain families at risk, but the Oxford team have come up with a few mutations that may indicate a genetic background to endometriosis. And I use the word may carefully because not all of these mutations you can go out and get, we've heard of 23andMe, the testing, you can buy at Boots. Unfortunately, that's not like that. We cannot just go there. But what we're looking at, probably advancement, is possibly even a salivary test, the Endo test that I'm sure some of our followers have seen being advertised. Again, it's not yet patented or not yet proven to diagnose endometriosis on a saliva test, but at least it's a progress in the right direction.
Does that excite you as a specialist in this area?
It excites me, but I'm worried also about the false positive, because having a label of endometriosis is not easy to bear. And essentially, there is the aftermath that comes about consequences of fertility, which we will be discussing, which can cause absolute anxiety and stress for an individual who's not aware of the potential implications. It's not to say, as I said earlier, not all women or individuals with endometriosis have infertility issues. Not all of them will have extreme complications as certain individuals. But yes, it excites me in one way that we all are making a concrete effort moving forward to streamline investigations, because it's such a vast diagnosis, and I think streamlining of the exact, because for fertility investigations, say for example, Eloise, we know that the man has to do a sperm analysis, for us ladies an ovarian reserve, but for endometriosis there is not a clear pathway as to what investigations to do first. So in that way it excites me.
This is very, very interesting. Thank you so much for expanding on this.
Pleasure.
I do have more questions for you, and if anyone watching has any questions, please feel free to ask. Also, head to our link in our bio when you have a moment to find out more about the team and the support and personalised care at CRGH Fertility Clinic, based in London, who offer 15-minute free consultations, which is an incredible opportunity that everyone should look into. So if you suspect you may have endometriosis, what would be your first steps?
So the question is if you're trying to get pregnant. If you're not trying to get pregnant, and if you have the symptoms, it's the duration and severity of symptoms, which is particularly important. Things like chronic pain, chronic painful periods, or heavy menstrual bleeding, or even other unusual symptoms like bowel symptoms, something we allude to as called as dyschezia, which is pain during defecation, or even urinary symptoms that have persisted for a long time, then it would be appropriate to seek medical advice. If it is you're trying to get pregnant and there is a suspicion of a background of endometriosis, the typical guidance that is out there at the moment is if you're under 35 years young, that is us women or individuals with a uterus, essentially if it's less than 35, if you're trying for about a year and not successful and have symptoms of endometriosis, reach out immediately for a gynecologist or a private fertility clinic or even your GP. But if you're 35 and above, then 6 months or more of trying to conceive with symptoms of endometriosis, reach out to the GP. Now, I must say here, Eloise, I personally think that time span, yeah, it's great for the generic public. But if individuals do have a diagnosis of endometriosis, I don't think 6 months or even a year is good enough. I do think we should be looking at shortening the time interval to 3 months. Now, I don't want everybody to jump into the bandwagon and immediately, overload our GPs and our secondary fertility care centers, but it's important that at least 3 months should be considered irrespective of the age.
I agree.
We are at the moment, we formed a group, a special interest group in this country, which is fertility preservation in individuals with endometriosis, a group that I'm part of, and we're looking at different pathways and evidence, because I can't just say, I think it should be 3 months without any evidence. But what I like to tell my patients and individuals is 3 months. If you're not conceiving and you have symptoms of endometriosis, reach out for help.
Okay, that's great. I want to ask you this question, which leads on from what we've just been discussing, and then we've had quite a few questions come in, so I'm going to ask you those. If someone reaches out and they come to CRGH for a consultation to discuss the possibility of endometriosis, what should they expect at that consultation? What will happen?
Very good question. It is a thorough medical history taking, because we need to ascertain the symptoms. What are the symptoms? And just to give you all an idea, it does not mean just because you have the symptoms you have endometriosis, not at all. Painful periods I've alluded to earlier, chronic pelvic pain. So we as medical professionals, we like to get a detailed medical history. Abnormal menstrual bleeding sometimes, we get in period bleeding in between our periods, and that could actually be suggestive of endometriosis. GI symptoms, gastrointestinal symptoms, abnormal periods of constipation, diarrhea, and quite often primary care physicians, no fault of their own, diagnose us as having irritable bowel, when actually we could be having underlying endometriosis. And also subfertility, if you're not using contraception and trying and you have symptoms of endometriosis. So those are the things we look at in a consultation, including a thorough medical history evaluation of the male partner as well.
What about the tests?
The tests, very good point. So the tests that we look for, of course, the sperm analysis, but in terms of us individuals with a uterus, you're looking at a transvaginal pelvic ultrasound scan and an ovarian reserve test. So we characteristically at CRGH, we do an ovarian reserve test between day 1 to day 5 of a period. We not only do an internal scan to see if there is any issues with adenomyosis, which is spots of endometriosis in the uterus, in the muscle wall of the uterus that could reduce implantation, but also to see if there is any peritonic sort of endometriotic nodules or any change in the anatomy, because what endometriosis does is it causes profound scarring in our pelvis, causing our anatomy to be a little bit distorted. So the vaginal scan will also pick up if there is any issues with ovarian accessibility, should we need to do any fertility preservation or fertility treatment. And in addition, what we look for is the presence of endometriosis on the ovaries, something we talk about as endometriomas. So those are the scans that we do. The tests which the ovarian reserve test would encompass is the anti-Müllerian hormone. Very important mark that anti-Müllerian hormone level is lower in individuals with endometriosis compared to the general population.
Okay, that's great to know. Thank you. May I ask you some questions which have come in?
Sure.
Some live questions. Can you develop endometriosis in your older years, or does it start early? It's a good question.
Very good question. I don't believe it is age related at all. And I think it's it is a condition that it is common. I do feel with technology advancing, the advancement of scans, ultrasound scan, the advancement of an MRI scan, we are diagnosing more individuals with endometriosis. So I don't believe it's an age-specific condition, not at all. As long as you're having your periods or your menstrual cycles, you more tend to essentially be diagnosed as having endometriosis.
Okay, thank you for that.
Pleasure.
Someone else has asked, excision or ablation to treat endometriosis?
Very good questions there.
Well read.
Excision and ablation, very important in the background of fertility. Because if you were to have a panel of endometriotic specialists, there will be a big debate, excision versus ablation. It's a topic at the moment at the American Society of Reproductive Medicine. So excision is normally recommended because you're sort of removing the nodule completely. So therefore, you're reducing the symptoms caused from the endometriosis. Ablation is good for mild endometriosis, where they're just minor spots and you just burn the spots off. But in terms of symptom relief, the surgeons are more opting for excision of endometriosis rather than ablation.
Does this have an effect or an impact on getting pregnant after such surgery?
Excellent question. So this is why surgeons always do an anti-Mullerian hormone test before the procedure and after the procedure, because remember, diathermy or electric current or ablation or excision or the instruments they use may have an effect on the egg reserve because of the electricity or the equipment they use may reduce the ovarian reserve. Say there is an endometrioma which is present in the ovaries, that could, excision of the endometrioma may actually result in a reduction in AMH. So quite often they like to check the AMH before and after.
That's really interesting to know. I didn't know that. Thank you for that. I hope that's answered this person's question. The next question, which I'd be interested to know your thoughts on the BCL6 test for endometriosis.
Okay, but remember a couple of things, Eloise, about these tests. Some of these tests are not even patented, and they have to be researched in a clinical research context before we can actually let it out and then essentially test for this. So in the absence of any concrete evidence, I would urge the audience not to jump the bandwagon and essentially go around testing for all of these tests, because we really don't know what is the implications of these tests. So at the moment, we check with, or we wait for the routine tests till we diagnose endometriosis. And if there is endometriosis, consider essentially fertility preservation.
Okay. Can you develop endometriosis in your older years? Oh, we've done that one.
We've done
that one. Thank you to everyone who sent these in. This is a lovely message. I thought I had endometriosis. I was trying to conceive. I went through CRGH for tests. She had a cyst. It got removed via IVF at CRGH, and she fell pregnant, and she had twins in May, age 44, which is amazing.
Coming to your point as well about BL6, as I said, what I didn't explain a little bit earlier, it's thought to be increased in individuals with unexplained.
Yes, absolutely.
So yeah, there is that false positive, and this is why even regards to the endo test, the BL6 testing, we have to always have this caution. And I tell all my patients, when things like we hear on the news about protein-rich plasma injections into the ovary for ovarian rejuvenation, all of these are unproven treatments or diagnostic tests. We have to be a bit careful rather than jumping in and doing these tests, and then we don't know what to do with this.
So best that people, speak to a fertility consultant such as yourself before jumping into making decisions.
Correct.
Yeah. Okay. Someone has said that they have stage 3 endometriosis, and their husband and themselves have been trying to conceive for many years. A doctor told them to see a doctor and consider Lupron injections. What are your thoughts on that?
But if they're trying to conceive two things, why would they be given Lupron? Because it's sort of defeating the purpose. Because Lupron is Prostap or things where it shuts down the pituitary ovarian axis, so therefore essentially enhancing the onset of a temporary premature menopause. So what they're trying to do is, by giving Lupron, you're sort of inducing a temporary menopause. So if they're trying, I was a little bit confused with the question, because if they're trying to conceive, Lupron is not the advisable dose. Lupron is used as part of certain down-regulation protocols before IVF. So it could be that maybe the fertility or the gynecologist is thinking in the future to consider fertility preservation for the couple. Again, it goes back to my previous point about age. So I would advise the individual in concern, look at their age, how long they've been trying for, and consider fertility preservation rather than doing Lupron endlessly.
Sounds like a good advice. Lupron acetate, is that used for trigger?
That's correct. It is used for trigger, but normally we don't use Lupron in this country. It's very difficult to source. So essentially, it's something we call the commercial name decapeptyl, and that is used as a trigger when there is a buserelin shortage. Eloise, so you're spot on, and you can see that you have been at CRGH because you know exactly what we're talking about. So yes, it is used as a trigger. Lupron is used in Europe and the States for downregulation before an IVF cycle. We don't use Lupron. We use more buserelin for downregulation.
Really, really useful to know. Thank you. Someone has said that they had endometriosis removal surgery, fell pregnant in the following month. After 4 years and cycles of IVF, unfortunately, and I'm very sorry, miscarried in July. Would you advise this person to try naturally or look into IVF being aged 35?
Sorry to hear about the pregnancy loss. Very, very upsetting to hear that, especially considering the length of time you both were trying to conceive. My strong advice is when you have endometriosis and you're trying for a considerable length of time with a history of miscarriage, I wouldn't waste time trying naturally. I would, not to say that you're not fertile, but it would mean that it would make sense to opt for fertility preservation. And something a little bit controversial because you're sitting on the cusp at 35 years young, maybe to even contemplate genetic screening for aneuploidy screening, because the HFA have suggested that the genetic screening for aneuploidy does aid reduce miscarriage risk.
Interesting. I've learned another thing today. Thank you for that. Someone has also asked, which is a great question, because we've talked a bit about egg quantity and AMH. What about endometriosis affecting egg quality?
Very pertinent questions, Eloise, if I may say the same. And this is what I was a little bit worried to be asked for, to be honest, because egg quality is something we cannot control.
Yes, absolutely.
It is age dependent. Number two, it is lifestyle dependent. And this is why patients who know me and individuals who've had treatment under my care, and even some of my colleagues like Dr. Saab, our clinical director, will know that he and me are absolutely pedantic on lifestyle changes to their lifestyle, because remember, the environment and stress and toxins can affect the egg quality. Add in endometriosis, which I always like to compare like rust on metal, and it tends to corrode into the egg numbers, but it has a profound effect also on egg quality. But unfortunately, at the moment, Alice, where we stand, there is no test for egg quality. And I think rather than the quest essentially for the right method of fertility treatment that would guarantee us 100%, I think the quest should be in infertility investigations. What is the test to determine egg quality? Because that will be the answer that all of us individuals are looking for.
Absolutely. Great advice. So many people have said thank you so much. This has been fascinating and excellent advice as always. So thank you so much for your time.
Pleasure.
I just want to ask one more question before we finish, if that's okay.
Sure.
Any precautions people should keep in mind pre a diagnosis, and also anything that people should consider if they've got an endometriosis diagnosis and are looking into fertility preservation or trying to get pregnant?
So rather than caution, advice.
Yep.
Essentially, I always feel, and remember, we live in this era of modern medicine, Eloise. We all have to be aware of our body, and we should learn not to ignore certain symptoms. Yes. We also need to understand, and things like, it is very relevant for us individuals as well as women in this context, is not only the incidence of breast cancer is increasing. I know that's not our topic for today, but we have to be aware of our own health. And if there is any symptoms that is worrying you enough, please reach out when in doubt, I always tell my patients, reach out, because then the medical professional will be able to gauge on whether we need to do any tests to ascertain a diagnosis. But caution is, we need to be a little bit not too overtly worried. Even if we have endometriosis, yes, why not overtly worried? Because now are the days where it is all about the patients.
Absolutely.
So essentially, if you're vigilant with yourself and you reach out, consistent efforts to reach out to the GP, healthcare professionals, and fertility specialists, then essentially I'm convinced that that individual will be successful in getting the right guidance, if that makes sense.
It does.
So a caution is about not letting it go, because this is very important for us individuals. And very important is, even if you're diagnosed with endometriosis, we are now, there are these wonderful charitable organizations, what I mentioned earlier, the Endometriosis Foundation, led by a dynamic individual. You know, we are living in a media, social media context where we're not isolated anymore, Elias. So all individuals from different backgrounds can reach out on social media, find out the impact, and then go well armed to their healthcare professionals for proper advice.
Absolutely. It's been such a wonderful, session. Thank you so much for all of your sound advice. I know everyone has
Eloise,
appreciated this.
I must say I'm very impressed with your questions and the audience questions. Dynamic, because not even in a scientific community we get asked.
I know. Everyone is very well read, and I would strongly advise people to take this opportunity of a free mini consult with the wonderful team at CRGH Fertility Clinic in London. Please follow our link in bio to find out more and book that. So thank you so much, Dr. Seshadri, for your time today and for joining me.
Pleasure, and I wish everybody all the very best and a fantastic journey ahead.
Thank you everyone else for joining. Great, lovely. Have a nice evening. Bye-bye.
Bye.